No, so I totally agree. There are situations, I think, that draw a lot of people into healthcare. They could be issues that come up in their lives. They could be crises. In my situation, my dad got bone cancer when he was 38. I was young. And he lived about 4 years. Well, during that time, like many people, when you're in a crisis, you can go one way or you can go other, or another. That my sister became a drug addict, and I had an English teacher at that time in high school who, I think everybody has had a person like that in their lives, where they make you feel, even if you don't have anything special, they make you feel that you are special, that you can do things. And she was that person for me. And she really helped me along. And because of her, I didn't go down a road that maybe I could have gone down. So if you fast forward about 35 years into the future, I heard that in my hometown she was in a nursing home and she had Alzheimer's. So I went to a bookstore and I got a book on grammar. And I wrote in a foreword to her, "Dear Mrs. So-and-so, I want to tell you, how much you changed my life, how much you affected me," and I did, and I wrote it out. So I went to the nursing home and I asked if I could see her, and she was in a wheelchair, I remember, sort of slumped over, looking very sad at the time. And they said, "That's her," and I went over, and she looked up and said, "Well, who are you?" And I said, "Well, I'm Ted Wolfendale, and I was a student of yours, and I wanted to come and see you, and I wanted to tell you how you changed my life." So she perked up a little and said, "Well, roll me down to my room," and I did. And we sat there. I sat on her bed, and I told her I brought a book. And I wrote in the front of the book for her how she changed my life. She said, "Read it to me." So now she's perked up even more. And as I began to read it to her, she was a completely different person. And she corrects my grammar, of course. And I get through, and we had just a really nice visit. Well, I would go back and see her. And each time that I would go back and see her, I would take another book and I would write something else. And she didn't remember me when I came in, but she remembered that other people had come in. So by the 5th or 6th time I came in, she was a completely different person for that point in her life. And she was perked up, and her life was different. I could see at that time. I know how Alzheimer's is, but for in that moment, she was different. And she said, "Wheel me down to my room," and I took her down to her room, and she had 5 or 6 of the books I brought on the shelf. And I said, "Well, I brought you a book, and I wanted to tell you what a wonderful teacher you were and how you changed my life." And she said, "Well, my students come and see me all the time. Look at all the books they brought me." So I think the point is, I'm not a brilliant researcher, and there are wonderful things that are happening with Alzheimer's disease in terms of new drugs that are coming out, things they're doing in Australia, things they're doing in the United States. We don't have to be these researchers that are making the drugs to make a difference. We got into this because we care about people. We care about the quality of life. And I think just through thinking about interactions that you can have with people, you can affect their lives.
Behavior management. Welcome back to Alzheimer's disease and related disorders. During this part of the program, we'll spend time examining specific behaviors that are both common and often problematic for the patient, family caregivers, and you, the healthcare provider. Alzheimer's disease does not affect memory alone. As we saw in part 1, it affects the entire brain. As the disease progresses, the following symptoms may also be exhibited: language difficulties, problems with executive tasks such as judgment, reasoning, sequencing, and planning, problems with perception, loss of motor skills, inability to carry out daily activities, and personality changes. All of these deficits lead to changes in behavior that can range from simple, repetitive behaviors and lack of interest to extreme agitation and violence. Several behaviors are observed in more than one stage. Oftentimes, the severity of the same behavior is increased in later stages. Just as we did in Part 1, we'll classify problematic behaviors according to stage of disease. We'll also discuss a general problem-solving approach to challenging behaviors and conclude by reviewing specific strategies and techniques for dealing with these behaviors. Before we discuss specific behaviors and management approaches, keep in mind that difficult behaviors can be more easily understood if we remember the following truths about behavior in general. First, all behavior has meaning, even if it's sometimes hard to determine what that meaning is. Secondly, all behavior has a cause and a result. For example, pacing is a common behavioral symptom that may be caused by anxiety. Thirdly, behavior does not occur in a vacuum, meaning there are outside or environmental influences that shape behavior. An example might be increased agitation, a behavior observed in a person with Alzheimer's disease who may have heard a troubling comment while watching the news but is unable to respond verbally. The behavior, therefore, is a substitution for what may otherwise have been their vocal disagreement with a comment or words of empathy for a child reported missing. Behaviors are rarely, if ever, random. Problematic behaviors, Alzheimer's disease, stage 1. These are behaviors that occur early, sometimes even before an individual has been diagnosed with Alzheimer's or a related disorder. An example may be the person who overacts with anger and verbal lashing when it is brought to his attention that a bill is overdue and was not paid. Blaming others for misplacing keys, forgetting to pick up items at the store, or not returning phone calls are symptoms that should be brought to the attention of the primary care practitioner. All of these behaviors may be indicative of short-term memory deficits. Additionally, these behaviors may cause the person with early-stage Alzheimer's disease to become angry and argumentative. Anger is likely to escalate when the person is accused of not being competent to take care of the bills or picking up the grandchildren from school. Even the suggestion that she needs help doing some things may be met with even more anger and argument. Problematic behaviors, Alzheimer's disease, stage 2. As memory deficits increase during disease progression, behavior problems become more frequent and severe. In stage 2 of Alzheimer's disease, paranoia and suspicious behaviors may be present. Word finding and identification of objects becomes more difficult for clients during this stage. Individuals with Alzheimer's disease will often accuse family members of stealing, hiding, or moving their personal belongings. In this stage, sleep disturbances and wandering may also become problematic. Problematic behaviors, Alzheimer's disease, stage 3. During stage 3, a client with Alzheimer's disease may scream or yell inappropriately and may resist your attempts to assist with activities of daily living. Also during this stage, the ability to verbalize decreases, and attempts at verbal communication are often garbled. Words have little meaning with regard to what the client is attempting to communicate. And finally, many of the behaviors observed during this stage 1 and 2 are greatly reduced or no longer observed.
Little sticks? I can't remember.
Addressing specific behavior challenges. Various challenging behaviors may present during the course of Alzheimer's disease. Some of these include agitation, vocal outbursts, wandering, and sleep disturbance that results in restlessness. Although there are medications available to treat these behavioral symptoms, all have side effects and may interact with other medications. Non-drug approaches are always preferable, and environmental and behavioral approaches should be attempted prior to resorting to medications. Let's take a look now at several challenging behaviors and specific strategies that may help both the family caregiver and you, the healthcare provider, deal with each of them. Remember that while these behaviors may be associated with particular stages of Alzheimer's disease, every person's disease process is unique, and these behaviors are not necessarily limited to the specific stages mentioned. Changes in abilities. Many family caregivers are able to articulate that the first sign of Alzheimer's disease in their loved one was a change in day-to-day abilities. Recall that dementia is defined as an acquired syndrome of decline in memory and other cognitive functions sufficient to affect daily life in an alert patient. From early onset through the end of stage 2, changes in a person's functional and communication abilities will be apparent. It is also, by definition, progressive and disabling. So the expectation for all involved should be that it will be a process that involves worsening over time, and there is no cure. This is an unfortunate but inevitable part of the disease process. You can encourage family caregivers by reminding them to make the most of good days and make the good times count. Denial is a dominant defense mechanism. Denial of memory problems occurs throughout first stage and into the early part of stage 2. Many clients in stage 1 will compensate by denial, making excuses, and projecting their deficit on family members and friends. While it may be difficult for you or family caregivers to accept misplaced blame, it is part of the transition throughout the disease. Forcing your client to face his or her memory loss will only result in anger and frustration, so it's best to allow the denial phase to occur. You can work with family caregivers to accept this common behavior and help them understand that it's merely a coping strategy. During early stage Alzheimer's disease, patients and family caregivers may also benefit from counseling. Besides memory loss and impaired thinking, Alzheimer's disease can produce daunting changes in behavior and personality. During the early stages of Alzheimer's disease, personality changes begin to occur as the affected individual is aware of, but often denies a problem exists. Oftentimes, an individual begins to withdraw from challenging situations to keep deficits from being apparent to others. It's important to educate the family caregiver that the disease is the cause of these behavioral changes. Acceptance of these changes as part of the disease promotes understanding between the client, family caregiver, and healthcare provider. Keys to coping with personality changes brought on by Alzheimer's disease include: accept changes each day as part of the disease. When in challenging situations, be available to support and fill in blanks for the individual when memories are incomplete. Satisfy the underlying needs of the behavior. Avoid criticizing, correcting, and arguing. Promote security and dignity at all times. In stage 1, early symptoms can cause the person to actively withdraw as it becomes increasingly more difficult to perform in social situations. In stage 2, limiting situations that may involve overstimulation will assist the person in maintaining some pleasant social interactions. Interaction with one or two friends will be more manageable than with a crowd, which could quickly become overwhelming. Promote rest between social times that allow the person to have time to regroup and re-energize. Here are some key points to remember. Anticipate demanding situations before they become uncomfortable. Plan for limited exposure times when many people will be present at large gatherings. Observe the person for increased anxiety and remove the person from the environment if necessary. Even individuals who were once very outgoing and comfortable in social situations should not be left alone during these times. Stay and provide emotional support and verbal assistance, but only when needed. Repetitive questioning. This behavior is most often exhibited in the later first stage and second stage of Alzheimer's disease. As the person moves into the later second stage and third stage, this behavior goes away. Although repetitive questioning can be frustrating, the following responses will assist you and family caregivers in coping with preservative behavior. Avoid arguing or any angry responses. Respond clearly and slowly to questions. Have the person repeat what you have said. Have the person write down the answer, such as the day of the week or the date, on a post-it note or in a tablet. When unable to write, leave short notes around about the details of the day or with the answers to commonly asked questions, as this may help with some repetitive questioning. Avoid responding with answers such as, "You have asked me that 5 times already," as they will have no memory of ever having asked. And impatient responses will only lessen their dignity and feelings of value. Storytelling. In stage 1 and stage 2, Alzheimer's patients can make up the most believable stories with amazingly vivid details. Understanding that the person truly believes these stories will assist family caregivers and healthcare providers to deal with this behavior most effectively. When storytelling or fantasies become an issue, look for clues in the story to determine underlying needs. Restlessness and agitation. During stage 1, the person with Alzheimer's is acutely aware of their decreasing ability to perform tasks like bill paying, book reading, and keeping appointments. This causes internal restlessness that results in the person becoming easily agitated over small things. Here are some coping strategies to deal with restlessness and agitation. Reduce noise and activity. Use a calm, reassuring approach that supports feelings. Consult a physician if agitation is difficult to manage. Incomplete tasks. In the first stage of Alzheimer's disease, as memory begins to wane, people will have difficulty completing tasks requiring multiple steps. This escalates through the first stage and into the second stage. You can assist in task completion by keeping instructions simple, posting step-by-step instructions to complete a task, put pictures or names on doors. For example, a picture of a toilet on the bathroom door. When the person moves through stage 2, healthcare providers and family caregivers should stand by to assist with verbal cues and reminders. The following actions will assist the person in maintaining independence. Maintain a routine. Avoid asking patients to do things at a later time. Keep them focused in the present. Avoid taking the attitude that it will be easier to do it myself. Keep the patient engaged and foster their success by giving one-step tasks to complete. When a task is completed, give another single-step task. Be overwhelmingly grateful for their assistance, as this may make cooperation easier when their participation is required on the next occasion. Provide step-by-step assistance for complicated tasks. Remember not to take over the project, but rather be a willing volunteer. Accusations involving money and finances. During the end of stage 1 and into stage 2, patients begin to experience confusion when dealing with the executive functions of managing bills, money, and their checking account. With the consent of the early Alzheimer's patient, family members should be educated about making legal arrangements to oversee finances. These arrangements are best made early when the person can express their wishes. Projecting blame in this area is very common and is most often done to compensate for decreasing abilities. There is no reason to argue, since the person with Alzheimer's disease truly believes they have been wronged and slighted financially. Because Alzheimer's patients often wish to have access to spending money, here are 2 practical tips for dealing with money matters. Family can arrange for a credit card with a small cap if the person is accustomed to carrying credit cards. Opening a second checking account is extra work, but may help the person with Alzheimer's to maintain their sense of self-worth and independence. They should be allowed to have money in their wallets and to make independent choices and purchases when making trips to grocery stores. They may make the same choice at each visit to the store and may amass quite a collection of gum or chocolates or magazines at home, but some tolerance in this area may be worth their feeling like a trusted decision maker in these situations. Clinging behavior. This behavior is seen in mid to late stage 2 and generally is due to fear of being left alone, which can lead to feelings of loss and insecurity. Diversion and keeping a daily schedule will help minimize this behavior. Here are some key points to remember. Identify fears and alleviate them verbally. Tell the person exactly what you are going to do, where you are going, and when you will return. A planned telephone call from a family member may be calming. Avoid dramatic changes in routine that may create anxiety. Schedule activities that provide a distraction, such as enlisting help with folding laundry, helping in the care of a pet, or watching a television program that is easy to follow, like game shows. Sexual inappropriateness. It is impossible to say how the disease will unfold for a given individual, but in some cases it brings about unwelcome sexual or seemingly sexual behaviors. Individuals with Alzheimer's often experience reduced sexual interest, but occasionally experience sharply increased sexual interest or acting out, known as hypersexuality. Other inappropriate behaviors, such as use of vulgar or obscene language, exposing oneself or undressing in public, collectively termed disinhibition, may not be sexual at all, but can be construed as such by others. These behaviors often appear in stage 2, when Alzheimer's disease begins to affect inhibitions and when people with Alzheimer's increasingly communicate through behavior instead of speech. At this time, frontal areas of the brain have been short-circuited and the person develops behaviors that are feel-good but not necessarily socially appropriate. Gently but firmly remind the individual that the behavior is inappropriate. Distraction is best used to deter this behavior, along with providing the individual with Alzheimer's disease opportunities for increasing levels of appropriate physical attention. Hugs, stroking the hair, massage, etc. Sometimes, providing the Alzheimer's patient with opportunities to interact with pets, children, and even stuffed animals will help in managing these behaviors. Be sure to discuss this behavior with a physician or counselor if it persists. Poor hygiene. Several factors may contribute to poor hygiene. As time becomes lost, the Alzheimer's disease person may think they just showered, when in reality it has been days. It is also common for the person to become frightened of the shower spray, the cold, or the loud sounds in a bathroom. This fear prevents them from showering regularly. Here are some tips to promote good hygiene. Schedule bathing regularly and keep to a predictable routine, such as time of day, the bathroom used, temperature of the water, the same smells of soap, creams, lotions, shaving products, towels, and bathrobes. Remember that inability to communicate displeasure with breaks in the routine may be manifested by struggling, refusal, or other acting out behaviors. Make bathing a relaxing experience by using music, candles, aromatic lotions and soaps, and warm cloths. Be aware of potential fears of water, falling, being cold, or undressing. Elicit the help of another person if needed to assure that the patient feels secure and trust that they will not be hurt. Wandering. Wandering and sundowning behaviors are seen during stage 2 and decrease in early stage 3. People with dementia may become more confused, restless, and insecure late in the afternoon or early evening when the sun is going down, thus the term sundowning. The person may become more demanding, restless, upset, suspicious, or disoriented during these times. Attention span and concentration become even more limited. Some people may become more impulsive, responding to their own ideas of reality that may place them at risk of leaving the home and wandering. Sundowning may relate to lack of sensory stimulation after dark, as at night there are fewer cues in the environment, with the dim lights and absence of noises from routine daytime activity. The patient may even see, hear, or believe things that aren't real, especially at night. A sundowning, restless person may also be hungry, uncomfortable, in pain, or need to use a toilet, all of which they can only express through restlessness. Keeping the patient active and engaged during the day is vital to keeping the sleep-wake cycle on track. Be sure to consult a physician if the behavior is persistent and use these techniques to minimize wandering and keep clients safe. Reorient the person who wanders in the house. Make sure the Alzheimer's patient gets plenty of exercise and movement. Indoor shopping malls are vast walking opportunities protected by the weather. Make sure the person is involved in many productive daily activities, such as the simple chores of folding laundry or washing vegetables for dinner. Reduce noise levels and confusion. This can disorient the person. Assure that doors leading to the outside are secure. Assure that there is not an unmet need related to some discomfort. Keep a light on for safety and decrease shadows which may be frightening. Consider that disorientation can be a result of medication side effects, drug interactions, or over-medicating, so report this behavior to the physician. Hallucinations and delusions. Hallucinations are sensory experiences that seem real to people with Alzheimer's disease, yet they are not really happening. The most common hallucinations are visual, seeing something that isn't really there, and auditory, hearing something that isn't really there. But hallucinations can also occur in regard to taste, smell, and touch. Most often, hallucinations and delusions occur during stage 2. During the actual hallucination, supportive, calming behavior works best to comfort the person with dementia. It is not helpful to try to convince them that they are imagining things. Instead, acknowledge their feelings, try to reassure that you are there to help, and redirect the patient to a pleasant activity. If it's a pleasing hallucination, for example, your patient sees birds and flowers outside a window that are not really there, there may be no benefit in trying to discourage or minimize the behavior. This behavior will need to be reported to the physician for follow-up and may require treatment with medication. Here are some key points to remember. Avoid arguing or disagreeing with the person. Rather, your focus should be reassurance and distraction. If you observe the person experiencing hallucinations, consult a physician. Provide the person with information about their environment in a calming voice as you attempt to reorient and calm fears. Show support for the feeling and the experience by saying, for example, "It must have been surprising to see those spiders," but suggest that now she needs to focus on getting ready for dinner and you need her to help by setting the table. Refusal to eat. As Alzheimer's disease progresses, individuals may forget to eat and lose the desire to drink. Use comfort food and aromas to increase appetite. Bread from the oven is great for this since the smell of baking bread brings back memories and can enhance appetite. Small, frequent meals can assist in maintaining weight and nutrition. During stage 3, swallowing may become problematic and the ability to eat, chew, or swallow becomes impaired as the end stages of Alzheimer's disease sets in. Here are some tips to stimulate appetite and maintain adequate nutrition. Exercise can make a person feel hungrier. The hungrier the person feels, the more likely they are to eat. Make meal times pleasant for the patient. Recognize that if the Alzheimer's patient does not like the person who is feeding them, they may not feel like eating. Try a different caretaker for the feeding process. Provide regular meals on a routine basis. Prepare familiar and favorite foods and avoid foods that are too hot or too cold, as these may be unpleasant to the patient. Chewing and swallowing difficulties can develop as Alzheimer's progresses. If necessary, give instructions on when to chew and when to swallow. Supplement foods with protein powders, eggs, etc. Offer flavorful, high-protein and calorie beverages after meals as a dessert. Some medications interfere with appetite. Be aware of the side effects of any medications that the Alzheimer's patient is taking. Failure to recognize familiar people and things. This behavior becomes more evident in mid to late stage 2. Calling attention to the behavior does not improve the situation and usually starts an argument. Persons with dementia become less capable with increased anxiety or excessive stimulus. Here are some key points to remember. Avoid arguing. This creates anxiety and limits recall ability. Use a gentle, relaxed tone of voice and stay calm. Don't quiz the person and don't react negatively if your loved one doesn't recognize something or someone. Calmly identify the person or thing. Be patient, flexible, and understanding. Avoid rushing. This decreases the ability to process information. The goals of care for individuals with Alzheimer's disease and related disorders include maintaining independence for as long as possible, encouraging ongoing participation in daily activities, and maintaining personal dignity and self-worth. All of these goals are especially meaningful as we look at activities of daily living, which include dressing, grooming, eating, bathing, and toileting. Let's look at how you can promote independence for your clients with Alzheimer's disease during each stage of the disease. Promoting independence at stage 1. What to expect. In the first stage of Alzheimer's disease, the forgetfulness stage, the person and the family caregiver may not realize there is a problem. Short-term recall problems, some intermittent word-finding problems, and personality changes are often attributed instead to fatigue, stress, or normal aging. Throughout this stage, the person with Alzheimer's disease will generally be able to manage personal care. Unless there is an underlying medical condition that otherwise impedes them, most individuals maintain continence of urine and feces. Eating continues to be independent, although food preparation may be less manageable as multiple-step cooking tasks become more difficult. During this stage, the person with ADRD may take longer to complete their daily routine for bathing and dressing, may forget to comb their hair, may not bathe as regularly or wear clean, matching clothes. To ensure the client at stage 1 is functioning at their highest possible level of independence, help them establish and mark designated places for important information and items such as car keys, checkbook, bills, phone, and credit cards. Also, post visual cues where possible to compensate for short-term memory deficits. Here are some examples. Put a list of important numbers next to the phone or on the refrigerator. If the person repeats questions and asks for the same information over and over, post the answers on the refrigerator. Finally, keep the bathroom safe and fully functional with these measures. Check for and dispose of old medications. Install a grab bar in the shower. Check to see if a raised toilet seat would be helpful. Be sure that hot and cold labels are clearly marked on sink and shower. Use non-skid rugs and mats to prevent slipping on the floor or in the tub. Ensure water temperature is not too hot and adjust as needed. Cushion the tub spigot so a bump or slip will be less likely to cause injury. Promoting independence at stage 2. What to expect. By the middle stage of the disease, it is obvious that something is wrong and the changes that are happening are not related to fatigue, stress, or normal aging. Early in stage 2 is generally when the disease is diagnosed and medical attention is sought. Family caregiver stress becomes evident at this stage as the daily functioning of the person with Alzheimer's disease is very unpredictable. Both you and the family caregiver will see days during this stage when the person is functioning well, and days when the person seems incapable of performing any task independently. Fluctuations in ability may also be noticed throughout the day. At this point, the person with ADRD will require supervision. They may not need constant supervision, but it should be available. As this stage progresses, the person with Alzheimer's disease may not be aware of the decline since they are no longer able to understand or process the changes that are happening. Activities of daily living can be challenging during this stage, and the strategy and techniques used will need to be modified as the stage progresses. Providing assistance with bathing and grooming during stage 2. In addition to fears, agitation, and increasing difficulty in expressing thoughts, disorientation to time will also affect an individual's ability to perform bathing and grooming activities. During this stage, the person with Alzheimer's disease might respond to a bathing request with, "I just took a shower." Here are some strategies that may be helpful to you in assisting your client maintain good hygiene. Alternate sponge baths with showers for those who resist undressing and getting into the shower. Replace the shower head with a handheld shower if the person seems fearful of the water spray. Check to see the person's reaction to the mirror. They may be fearful of their own reflection, not recognize themselves, and think someone else is in the bathroom. If this is the case, try covering or removing the mirror entirely. Use quiet, soothing music to set the tone and decrease stress during bath time. Approach grooming as a pampering time. Do 100 strokes of the hair, have a foot soak, and rub lotion on their feet. Soak hands for a manicure and nail cutting. Ask for help to encourage participation. Can you show me how a shave is done? How do you use this electric razor? Can you help me to learn this? In stage 2, confusion and inability to sequence becomes more evident. The person will experience more difficulty in selecting clothes and also have difficulty determining the sequence of dressing. It is in this stage that the person with Alzheimer's disease may put their underwear on over their shirt or pants. Coordinating clothing becomes very difficult, and clashing colors, patterns, and inappropriate layering of multiple shirts is common. Clients may also want to keep the same clothes on and refuse to change into a different outfit. Some strategies that may assist you and the family caregiver in this area include: cull the wardrobe to decrease selection and decisions. Keep choices to a minimum. If having clothing pulled over their heads seems to frighten your client, provide blouses or shirts with large buttons. Lay out clothing in advance in the order the clothes should be put on the body. For example, bra, underpants, socks, pants, top, sweater. If your client has a preference for one color or a particular outfit, arrange for multiple sets of the same clothes to facilitate laundering. Select comfortable fabrics that are loose and washable. Providing assistance with eating during stage 2. In stage 2, eating may become erratic, and the person with Alzheimer's disease may experience weight loss or weight gain. As Alzheimer's disease progresses, the sense of taste and ability to smell may be diminished, and that takes away 2 normal biological appetite boosters. An increased confusional state and loss of short-term memory during this stage makes mealtimes especially challenging. For example, selecting foods at a table and using utensils may be too difficult for the person to perform as this stage progresses. Let's look at some tactics you can use to help maintain nutrition and adequate weight during this stage. Select meals at the same time each day. Turn off the television and reduce distractions. The person in this stage needs to concentrate efforts on the task at hand, which is eating the meal. Other household distractions should also be minimized at mealtime. Kids laughing, playing games, loud music, boisterous conversations with friends, etc. A quiet room might be designated for meals. Try serving 6 smaller meals and use finger foods that can be consumed while moving about. Patient might be overwhelmed by a full dish, even if it is a very small one. Try to use a large plate or bowl containing a small serving, as this may appear more manageable to the patient even if it is the same amount of food being presented. Minimize junk food. Use snack times to boost nutrition by serving fresh fruit slices with yogurt for dipping, crackers with cheese, or peanut butter. Don't deprive patient of favorite foods like chocolate. Instead, provide small slices of a chocolate-covered protein bar that you can offer as candy. Be creative to enhance cooperation and maximize nutrition. Use aromas to stimulate appetite. Use a bread maker, store-bought cookie dough, or simmer cinnamon sticks in boiling water. Providing assistance with toileting and incontinence during stage 2. Persons with Alzheimer's disease-related disorders begin to develop incontinence as stage 2 progresses. Incontinence includes loss of bladder, as well as bowel control, and includes bedwetting. This is a difficult problem for family caregivers and healthcare providers. If incontinence is a new behavior, the first step is to identify possible reasons and take action. There are several causes of incontinence that are not based on disease progression, so it's important to first rule out medical origin. Here are some recommended assessment questions. Could the person have a urinary tract infection? Are they constipated? Could the male have a prostate problem? Does the person have diabetes? Is mobility an issue? Are movements painful, making it difficult to get to the bathroom? If any of the above are answered yes, a consult with the physician is indicated for further assessment. Other possible causes of incontinence include stress, medication, an environment that makes it difficult to navigate to the bathroom, and clothing that is difficult to remove. Try the following to eliminate or reduce incontinent episodes. Keep a log to identify voiding patterns and begin timed toileting. Encourage fluid intake throughout the day, 6 cups for good hydration. Use decaffeinated teas and coffee that do not stimulate diuresis. Watch for visual cues such as fidgeting in chair, grasping crotch area, or rubbing of the lower abdominal area. Use a bedside commode to prevent falling and night incontinence. Incontinence is an embarrassing development for the person with Alzheimer's disease, and helping the person maintain dignity during these episodes is essential. Healthcare providers need to assist the family caregiver in understanding that this is part of the disease, and that reassurance and non-judgmental statements will help the person with Alzheimer's maintain a feeling of acceptance and dignity. Promoting independence at stage 3, what to expect. In the late stage of Alzheimer's disease, patients are totally dependent on the family caregiver and the healthcare provider. The person will require constant supervision and assistance with all activities of daily living. Clients will require assistance with bathing, grooming, toileting, eating, ambulating, and dressing. The person in this stage may walk, but will have an unsteady gait with fumbling and poor coordination. Falls are common. Memories, both short and long term, are severely impaired. The person may not be able to speak or understand words. They may not recognize their family or friends and may not be able to identify themselves in the mirror. They may have difficulty coordinating the steps of biting, chewing, and swallowing, making nutrition an issue. There is typically weight loss during this stage of illness. Yelling and screaming, as well as reflex withdrawal during personal care, is not unusual. During the end stage of Alzheimer's disease, the family caregiver needs education on providing total physical care, assessing for skin breakdown, monitoring nutrition, hydration, and palliative care strategies. Providing assistance with bathing and grooming during stage 3. Keep the bathroom free of clutter. Use a shower chair and do not leave the person unattended in the shower or bath. For men, an electric shaver may be easier than a razor shave. Use dry shampoos if the person is frightened of water spray over their head. Assist with oral hygiene. Use swabs instead of a toothbrush if your client is resistant to having his or her teeth brushed. Consider using an electric toothbrush. Watch for any changes in skin color, consistency, look for blistering or rashes, and communicate to physician any skin problems identified. Providing assistance with dressing during stage 3. Select loose, comfortable clothing that is easily washed. Consider adaptive clothing with Velcro. Loose-fitting socks will promote comfort and decrease friction on the bed and chairs, which will decrease pressure. Providing assistance with eating during stage 3. In the last stages of Alzheimer's disease, chewing and swallowing can become difficult. Here are some suggestions that may be helpful. Use rough, textured foods, such as toast, to stimulate the person's tongue and encourage chewing. Gently move the person's chin to begin the chewing activity. Stimulate chewing by touching the tongue with a fork or spoon. Light stroking of the throat area can remind the person to swallow. Add a commercially available thickener to liquids to help prevent choking. providing assistance with toileting and incontinence during stage 3. Adult diapers are readily available and come in various sizes. Pull-ups are available for those who are still mobile and use the toilet. Bowel programs can assist in managing stool incontinence. Using prune juice, stool softeners, coffee in the AM, and promoting after-meal toileting can establish a bowel regimen that prevents accidents. Meticulous skincare to the perineal area is required to prevent skin rashes, urine burn, inflammation, and pressure ulcers. Use a gentle soap and skin barrier product to help maintain skin integrity. Consider use of a handheld shower head for thorough cleansing after toileting. Now let's turn to the final part of our program, developing skills for working with families and caregivers. Once again, we'll examine how the type of assistance you provide depends on the symptoms and behaviors being exhibited by the person with Alzheimer's disease. Stage 1. In the early stages of ADRD, concerns of the family are similar to the person who is experiencing the memory deficit and early changes. For example, family caregivers and those in early Alzheimer groups report some of the same feelings when first diagnosed. Some of the most common reactions include depression, denial, anxiety, fear, isolation, embarrassment, feeling of loss. In stage 2, many changes occur that have altered the role of the family caregiver. The primary family caregiver is now caring for a person that requires constant supervision and support. During these years, the family caregiver sees their loved one slowly leaving them, one memory at a time. It is devastating, demoralizing, and demanding to care for a loved one at home. Feelings of isolation, loneliness, and hopelessness are common. This is the longest stage of Alzheimer's disease and is the most labor-intensive and frustrating for the family caregiver. Sleep disturbances and incontinence become a part of daily life for the family and the client. Through this stage, the needs of the Alzheimer's patient can become all-consuming, and family caregivers have little time for anything else. In the early middle stage, the person with Alzheimer's can still handle some of their daily activities, but can become confused and frustrated when they have difficulty with sequencing tasks that require executive functions. Managing a checkbook presents many challenges. Personal hygiene sometimes becomes an all-day ritual, and changes in behaviors by the hour, day, and week are common. Behaviors that would never be displayed sometimes appear and cause immense distress to families. Family caregivers continue to have many questions and concerns during this time. By now, you should have a clear understanding of the concerns and pressures family caregivers face. Unfortunately, new and different challenges exist for family caregivers during stage 3. As the disease progresses, a stranger emerges, and this stranger requires increasing time and effort as the physical and emotional care becomes a 24-hour-a-day activity. During the end stage of Alzheimer's disease, the person is a shell of their former self, requiring care and assistance with all functional activities. They may be nonverbal or may have speech that is not understandable. By this stage, family caregivers have generally resigned themselves to the disease and the daily routine that they have established over the years. They have become adept at handling their loved ones, have made accommodations as necessary, and are quite creative in managing the task of caring for a person who has minimal mobility and requires feeding, bathing, dressing, toileting, and grooming. The underlying emotion in this stage is grief. The grief experienced by a family caregiver of a person with Alzheimer's is not the traditional grief that we are familiar with, which is experienced as a reaction to a loss. This type of grief spans years, from the first uttering of the diagnosis until well past the death of their loved one. This is sometimes referred to as anticipatory grief. Anticipatory grief is conceived as limited. In other words, a person reacts to the foreknowledge of an impending loss. Grief can be complicated by caregiving. Not only is the family caregiver grief-stricken by the ravages of the disease on their loved one, but they grieve their own losses. Personal friendships, recreational activities, work roles, and personal desires have all taken a back seat to their caregiving role. As the person dies, some caregivers and families experience guilt at the relief of the final exit of the person that they once knew. Primary family caregivers can experience grief at the loss of their caregiving responsibilities. The journey is so long that they have forgotten how to engage in social, recreational, or diversional activities. The home care professional can assist during this stage by continuing to provide support, education, and ongoing advocacy of family members. This concludes the final portion of understanding Alzheimer's disease and related disorders. We trust that this program has provided you with a deeper understanding of Alzheimer's disease and related disorders, and hope that you are better equipped to care for your clients and their families. Until next time, I'm Melanie Ryan for National Educational Video.